have neonatal hypocalcemia, which usually persists for greater than 14 days post-delivery, and is associated, is present despite the fact of a low parathormone level. In the children with a complete, so-called complete DiGeorge, who are actually athymic, bone marrow transplant has not been terribly successful, because even if you replace the stem cells, they still don't have a thymus for those stem cells to mature into. However, more recently, some children have undergone thymic transplants, which at present is looking like a possibly successful alternative to bone marrow transplant, and can offer these children a bit more hope. Wiskott-Aldridge syndrome is an X-linked condition that was originally described having the classic triad of severe eczema, a mixed immunodeficiency involving T cells, B cells, and innate cells, and a microcytic thrombocytopenia. In addition to these characteristics, it also has a susceptibility to autoimmune diseases and a susceptibility to malignancy. Diagnosis is strongly suggested by looking at the blood film, which shows low volume, low numbers of platelets, and can be confirmed by molecular testing. There is a hypomorphic, or less severe form of Wiskott-Aldridge syndrome called X-linked thrombocytopenia, which only has the very low platelets, which still have a very low volume of platelets, but no eczema and no susceptibility to infection. Here we have a baby suffering from Wiskott-Aldridge syndrome, and you can see the very widespread eczema all over his body, and you can see the bleeding that has gone into the skin around that because of his thrombocytopenia. And on the right here, you can make out with a bit of an eye of faith that on the top panel you have a normal child with reasonable volume platelets, and in the bottom panel, there's only a couple of platelets there, but those that are do appear to have very low volume. The defect in Wiskott-Aldridge syndrome is rather surprisingly a coordinator of the actin cytoskeleton, and in fact the defects in this condition are very complex and include migration defects of most immune cells in the body. X-linked agammaglobulinemia, or Bruton's disease, is a primary antibody deficiency. So these children have a defect in a gene that is involved in the signalling downstream from a surface immunoglobulin, and therefore on encountering antibodies, the B cells are unable to signal to allow them to activate and to proliferate. An X-linked pedigree can be found in approximately 30% of children, which obviously suggests that there's quite a relatively high de novo mutation rate. These children have low B cells or absent B cells, usually with a CD19 count of less than 2%. Similarly, they should have low or absent IgG, A or M. So these children are not able to generate any immunoglobulin from a primary response. The problem is not a difficulty with class switching. They have very poor responses to vaccines, and they're susceptible to capsulated organisms, so pneumococcus, Haemophilus influenzae, in addition to Staph aureus, Neisseria meningitidis, Moraxella, and Mycoplasma. They have a particular susceptibility to enteroviruses and are at risk of enterovirus viral meningitis. And for these children, that is not a self-limiting condition, and this condition can actually be fatal or can lead to permanent damage. Interestingly, the incidence of these children getting enterovirus meningitis is reduced if they're kept at, if their immunoglobulin levels are kept at high levels. And treatment of these children is replacement immunoglobulin that can be intravenous or it can be subcut, and prophylactic antibiotics, and early use of aggressive antibiotics when they become unwell. Children with XLA, X-linked agammaglobulinemia, are particularly vulnerable to developing bronchiectasis, and it's important that their chests are monitored regularly. The majority of these children present before 1 year of age, and by far the most common presentation is with sinopulmonary infections. There is a condition called transient hypogammaglobulinemia of infancy, which can mimic X-linked agammaglobulinemia, but generally the children are not so symptomatic, and they tend to grow out of it by the age of 2. By far the most common antibody deficiency is IgA deficiency. This has an incidence of approximately 1 in 500, but is usually asymptomatic. IgA is critical for mucosal immunity, and it's, although produced by plasma cells in the bone marrow, it is secreted from the blood onto mucosal surfaces, mainly in the gut and in the lungs. It has an important effector function, both as a blocking antibody, preventing pathogens from entering the body, but also as an important activator of the alternative complement system. IgA deficiency, however, is not always symptomatic. It's frequently associated with IgG2 deficiency, which is more likely to have problems with immunodeficiency, but also may be completely asymptomatic. There is quite an overlap with common variable immunodeficiency, or CVID, that we'll talk about in a moment. If patients are susceptible to infection, they tend to get respiratory infections, sinus infections, and gastrointestinal tract infections. Atopy and autoimmunity are very common, and in particular, IgA deficiency is associated with ulcerative colitis, Crohn's disease, and celiac disease. CVID, or common variable immunodeficiency, is a mixture of many different conditions which are quite heterogeneous. It appears to have 2 peaks of onset, one at less than 5 years of age, and a second in the 2nd or 3rd decade of life. It has problems with antibody deficiency, frequently with an inability to make specific antibody responses. And the types of infections that patients with CVID are susceptible to is quite similar to XLA, but far less severe. Like patients with XLA, these patients are at risk of developing bronchiectasis. However, a more prominent component of the pathogenesis of CVID is autoimmunity, of which ITP and thyroid problems are most common, and granulomatous disease, which can affect the gastrointestinal tract, lungs, and the skin. So, question 5. Which of the following are true statements regarding common variable immunodeficiency? Patients are particularly prone to viral infections. B. Circulating B cell numbers are usually normal. C. IgG levels are normal. D. It typically manifests as an autosomal recessive inheritance. Or E. Patients are at increased risk of malignancy. Well, B and E are true. The others are false. So, as we've discussed before, this is a humoral deficiency, and therefore there is no increased susceptibility to viral infections. Usually, circulating B cells are normal, as are IgG levels. Some rare forms of CVID do have an autosomal recessive inheritance, but generally there is no pattern, and the vast majority of patients with CVID do not have any inheritance pattern at all. Patients are at risk of malignancy, although nowhere near as great a risk as many of the other T-cell immunodeficiencies. And question 6, a 16-year-old suffers recurrent proven bacterial chest infections requiring regular antibiotic treatment. Which of the following is the best way to exclude an antibody deficiency? A. Serum immunoglobulins. B. Immunoglobulin subclasses. C. Specific antibodies to Haemophilus and pneumococci. D. Complement levels. E. Mannose binding protein. Well, I hope you'll be shouting out the answer C, because as we've said before, the best functional assessment is to look at responses to vaccination. And particularly in a 16-year-old girl, who it would be extremely unlikely that she would have a profound absolute agammaglobulinemia. It's much more likely that if she does have an immunodeficiency, it's going to be on the CVID spectrum. And therefore, assessing her functional antibody responses is going to be a much more useful test. So, intravenous immunoglobulin. There is a worldwide shortage of IVIG at the moment, and therefore the Department of Health has issued guidelines as to which conditions it should be allowed for, and which there is no current evidence that it will provide any benefit to the patient. And from a paediatric perspective, the major conditions which have either been definitely recommended or recommended for some patients are listed here. Primary immunodeficiency is rather obviously one of those, because there is no alternative. And similarly, Kawasaki's disease, the evidence for its benefit is fairly extensive. Alloimmune thrombocytopenia in a neonate and autoimmune blood cytopenias, it is recommended in certain patients, as is the case for Guillain-Barré, dermatomyositis, Stevens-Johnson, and toxic shock syndrome. The latter two, if the patient is already on intensive care. Ataxia-telangiectasia is a immunodeficiency associated with a far wider systemic disease spectrum. These children have a progressive cerebellar ataxia without a developing microcephaly. And associated with this, they develop a chorioathetosis. From 2 years of age, they develop oculocutaneous telangiectasia. They have growth retardation, and they're susceptible to lymphoid malignancies. The gene that's abnormal maps to a chromosome 11q2223 and codes for a protein called ATM, which is known to be important for repairing DNA breaks. And ataxia-telangiectasia is one of a range of immunodeficiencies that are involved, that are caused by mutations in the DNA double-stranded break repair system of the body. From an immunological point of view, these children are particularly susceptible to recurrent sinopulmonary infections, and they have reduced levels of IgA and IgG. They do also have subtle T cell defects with reduced thymic output, so reduced numbers of naive T cells, and a restricted T cell repertoire, so a more limited ability to respond to for T cells to respond to antigens. I would just like to end on immunodeficiencies by putting up a slide showing a list of one, not quite an exhaustive list, of X-linked immunodeficiencies, because it is slightly unusual to have an area where so many conditions are X-linked. We've already mentioned X-SCID, or common gamma chain SCID, and X-linked agammaglobulinemia. We haven't mentioned the most common neutrophil disorder, which is chronic granulomatous disease, which is a condition whereby the neutrophils and macrophages of these patients are unable to launch an oxidative burst to kill bacteria once they've phagocytosed them. And as a result, these children are susceptible to pyogenic infections and also develop granulomas, and frequently have problems with colitis relating to that. The diagnosis is made by doing a test called an NBT, or a nitro-blue tetrazolium test, and treatment is largely supportive with prophylactic antibiotics, often cetrin or ciprofloxacin, although children have also been bone marrow transplanted as well. CD40 ligand, or hyper-IgM syndrome, is X-linked, as is Wiskott-Aldrich syndrome, and Duncan's disease, or XLP, X-linked lymphoproliferative disorder, is also X-linked. And finally, a condition called IPEX, which stands for immune dysregulation polyendocrinopathy, and X-linked, is a disorder that has immunodeficiency, but also associated with multiple autoimmune problems. So, time for a slightly different tact and a chance to move on to some autoimmunity. Which of the following autoantibodies are correctly linked with the disease in which they are associated? A. Anti-esterase antibody in myasthenia. B. Anti-endomysial antibody and celiac disease. C. Anti-acetylcholine antibodies and spinal muscular atrophy. D. 21-hydroxylase antibody and congenital adrenal hyperplasia. Or E. Anti-epidermal antibody and vitiligo. The answer is B. Anti-endomysial antibody and celiac disease. Anti-endomysial antibodies are IgA antibodies, therefore it is essential to check the level of IgA when testing a patient for celiac disease, because although this antibody is far more sensitive and specific than other autoantibodies, in the presence of IgA deficiency, which is associated with celiac disease, it becomes fairly useless. Anticholinesterase antibodies, anti-acetylcholinesterase antibodies are the autoantibody in myasthenia gravis, and spinal muscular atrophy and congenital adrenal hyperplasia are not associated with autoantibodies. So, rather obviously, I'm not going to try to do a complete rundown of the science behind autoimmunity in 4 slides. However, I think it is useful just to put a few ideas which might help you approach conditions with autoimmunity as questions come up. So the first idea is to see that autoimmune conditions tend to be separated into those that are systemic, such as SLE or rheumatoid arthritis, or organ-specific, such as Graves' disease or myasthenia gravis. Also, it's important to remember that there are many cells within the immune system which may be contributing to this autoimmunity. And T cells, B cells, cells of the innate immune system, and antibodies all play different roles in different diseases. And we can take you through some of the examples of this. So autoantibodies, for example, may be just a marker of disease, such as in insulin-dependent diabetes mellitus, where it is felt that the predominant damage is done by cytotoxic T cells attacking the islet cells. But once that damage has been done, then autoantibodies are able to be generated by exposure of antigens that are not normally there. Secondly, autoantibodies may cause disease by blocking function. And an example of this is the anti-TSH receptor autoantibody produced in Graves' disease. Alternatively, autoantibodies may be directly responsible for the pathogenicity of the condition. In Goodpaster's syndrome, autoantibodies are generated against collagen in the basement membrane of the lung epithelium. As a result, these antibodies stick to the membrane, and the Fc portion of the antibody is then able to recruit mediators of inflammation, such as neutrophils, basophils, and mast cells. This then results in a massive increase in inflammation and tissue damage. An alternative way in which autoantibodies cause disease is demonstrated by ITP or hemolytic anemia. Here the autoantibodies bind to the platelets or the red cells and as a result opsonize them to allow these cells to be removed by the spleen. Or alternatively, they initiate a complement cascade resulting in formation of a membrane attack complex, which then kills either the platelets or the red cells. One area of autoantibodies which I always found very confusing was anti-nuclear antibodies. So anti-nuclear antibodies are a mixture of autoantibodies against a cell's nucleus. They can be detected by either ELISA or by direct visualization using immunofluorescence. They're important because they have quite strong associations, if not terribly specific associations, with a number of systemic autoimmune diseases. And 80 to 90% of patients with specific associations with a number of systemic autoimmune diseases. And 80 to 90% of patients with SLE have anti-nuclear antigens, and 60% of patients with Sjogren's syndrome, in addition to a number of other autoimmune diseases. As I've said, anti-nuclear antibodies are actually a complete mixture of many, many different antibodies. And to try to tease these out so that maybe they can give more specific information, they're initially divided into extractable nuclear antibodies or anti-ENAs, and these are antigens that are soluble and can be washed out in saline from the nucleus of fixed cells. This relates to the practical technique of actually detecting them. And they tend to be associated with a speckled staining pattern in the nucleus of these cells, and hence the reports that come back saying ANA speckled. Those autoantibodies or antigens that are not washed out include anti-double-stranded DNA and anti-centromere autoantibody. So the anti-ENAs are also made up of a mixture of antibodies, And four that are regularly tested in laboratories are anti-SM, anti-RNP, anti-LAR, and anti-Rho. The SM, LAR, and Rho refer to the names of the initials of the patients on whom these autoantibodies were first discovered. The anti-RNP refers to an anti-nuclear ribonuclear protein autoantibody. The importance of all of these is that by selecting various more and more specific autoantibodies, it is able to you are able to aid your diagnosis of systemic autoimmune disease. And in red here, I've labelled the autoantibodies that are most specifically associated with SLE, and in blue, those that are most specifically associated with Sjogren's, so LAR and Rho. And in green, the anti-centromere autoantibody is most associated with scleroderma. SLE frequently also has anti-LAR and anti-Rho antibodies, but not with the same sensitivity that Sjogren's syndrome does. There are many aspects to the disease pathogenesis in systemic lupus erythematosus. However, one aspect I would like to consider here is the fact that when tissue is damaged in SLE, along with cell death and cell necrosis, the nuclear antigens become exposed and therefore stimulate the autoreactive B cells to produce more immunoglobulin. This then drives forward a vicious cycle leading to more recruitment of cells of the innate immune system, resulting in a greater inflammatory response and further tissue damage and more autoantibody production. The net result of this is that the body or the bloodstream gets flooded with an excess of immune complexes of autoantibodies bound to self-anti-nuclear antibodies. And like in other type 3 hypersensitivity reactions, when there's a vast excess of immune complexes, such as in the Arthros reaction, these complexes get deposited in places. And one common place is the glomerular basement membrane. Once deposited in the glomerular basement membrane, these complexes then attract and activate neutrophils and mast cells, which drive forward a damaging inflammatory response. In conjunction with this, complement becomes extensively activated, resulting in further inflammation and marked complement consumption. As a result of this, blood tests in SLE frequently show low levels of C4 because the liver production of complement cannot keep up with its consumption rates. One further aspect of autoantibodies in SLE is that, as discussed on the previous slide, anti-Rho and anti-LAR antibodies are often, but not exclusively, positive in SLE. If they are present, however, in a mother, the baby is at much greater risk of developing conduction defects in the neonatal lupus syndrome. And finally, question 8. In a 16-year-old female with systemic lupus erythematosus, which of the following investigations statements is true? CRP is typically normal in non-infected patients with active disease. Rheumatoid factor is positive in less than 5% of patients. Neutropenia is more common than lymphopenia. The low-dose oral contraceptive pill is contraindicated. Pulmonary fibrosis is a common disease complication. And the answer is A. the CRP is typically normal in non-infected patients. Rheumatoid factor is positive in approximately 50% of patients, and pulmonary fibrosis is only a rare complication. In SLE, it's more common to have lymphopenia than it is to have neutropenia. Okay, so in this talk, I hope I've given you a rounded introduction to primary immunodeficiency, and I hope should you get a question on immunodeficiency of any sort, you should feel confident to address that and get all the marks for it. I hope I've provided you with an understanding of how specific immunodeficiencies have specific patterns of infection. And I hope we've been able to compare the clinical presentation of conditions with T-cell defects to those with humoral defects. I also hope I've introduced you to some of the immunopathology underlying autoimmune diseases, and that this might give you a bit more of a handle on approaching some of these conditions as well. Best of luck.